Hello, my name is Zoe Quinn-Kelly and I am Dr. Harkess's PA. And you have been scheduled for a total hip replacement. So the point of this presentation and this video is just to go over everything. What to expect before, during, and after surgery. I do recommend that you either grab a notebook, take some notes, write down any questions that come up during this presentation, or alternatively, right below this video should be a link for the slides. And if you want to just print those out and take notes directly on the slides, feel free to do that. The goal of this video is to give you the opportunity to watch it many times, have anyone who's going to be taking care of you or helping you along this journey watch the video as well. We will be giving you a call, either I or Dr. Harkess will be giving you a call before surgery, usually in the 1 to 2 weeks before surgery, at which point we'll talk to you about any other questions you might have and go forward from there. So what does your hip look like? Your hip is made up of two bones, your femur, which is your thigh bone, and your pelvis. Now, the femoral side of your hip is a ball that we call a femoral head. And the socket part, which is in your pelvis, is an area that we call the acetabulum. Both of these areas are covered in cartilage, or they're supposed to be covered in cartilage, which is a smooth tissue that basically cushions the ends of your bone and are supposed to allow that joint to move easily, freely, and pain-free. Now, when you have an arthritic hip, what's happened is that arthritis is basically a degenerative disease of the cartilage, meaning that over time, that cartilage has started to wear away. So as you can see in this x-ray, this person has bone-on-bone arthritis, and they've lost all that space in between the ball and the socket where that cartilage lives. And all of that has caused a lot of irritation, pain, and even some bone spurs to grow there. Now, what does a total hip replacement look like? So what we do is we actually remove the femoral head, and your femur, or your thigh bone, has a hollow center. And so what we do is we put a metal stem in that hollow center, and there is a ceramic ball that's attached to that stem. So that's kind of mimicking your femoral head. We also prepare the acetabulum to accept a metal cup, and then you get a plastic liner in there. That way the bearing surface is now ceramic on plastic, and that should allow for smooth, easy, and pain-free motion. Anytime you have surgery, there's always going to be some risks involved with surgery. Now, we do not plan on any of these things happening to you, and for the most part, there's a very, very low probability that any of these things will happen, but we do need to just discuss it so you're aware of the possibility. So anytime you undergo anesthesia, there are always risks of medical complications, things like heart attack, stroke. That's why we get the double thumbs up from your primary care provider and your cardiologist if you have one. Now, as far as hip replacement specific risks, anytime we make an incision in your skin, there's always a risk of infection or bleeding. Now, there are certain conditions that do make you more prone to infection. Smoking is one of them, and we do ask that you quit smoking 6 weeks prior to surgery. If you have a high BMI, that does put you at greater risk for infection, as well as if you have diabetes. That really can create some issues with wound healing, which is why we're very adamant that you keep good blood glucose control before, during, and after surgery. We are also going to be checking an A1C if your primary care has not already checked that recently, to make sure that it is not too high to proceed with surgery. Now, as far as bleeding is concerned, this is why we ask that you come off of any medications that can make you prone to bleeding beforehand, especially if you are on a blood thinner. And we do make sure that we control that bleeding as best we can during surgery itself. Now, after surgery, we're actually worried about the opposite problem, which would be blood clots. So We will be putting you on either an aspirin twice a day to prevent blood clots. That's kind of for our standard patient. But if you have any allergies to aspirin, or for some reason have some history of blood clots, especially after a surgery, we will be putting you on something stronger, most likely a medication called Xarelto. Now, obviously, if you're already on a blood thinner that you've stopped prior to surgery, we will be restarting that the very next day after surgery. Anytime you have surgery, you will also be at risk for developing a hematoma, which is basically just if you have blood that kind of collects underneath your incision. Again, very rare. Also rare to have a nerve injury, but it is always a possibility. Now, when it comes to hip replacement itself, there is always a risk of a leg length discrepancy. So over time, when you've had arthritis, you may have actually lost some length in your leg, but it's happened so slowly that you haven't really noticed. And so your muscles have kind of readjusted to that. We take x-rays in the operating room of your pelvis to try to make sure that your hips are as even as we can possibly make them. However, there are some instances where we would intentionally increase the length of your leg. Now, we're talking on the order of millimeters. Most people would never ever even notice. But if on the rare chance that due to stability reasons in surgery that we had to intentionally increase your length, and on the rare chance that it was noticeable and bothersome to you, we can always put a little wedge in your other shoe. But most often, as long as you get up and move after surgery and you work with physical therapy, a lot of times once your soft tissue readjusts, even if you had a leg length discrepancy right out of the gate, it often will correct itself. Now, there's always going to be a risk of loosening or failure of your implant anytime we put something into the body. And if that were to happen, we would have to do a revision surgery. Again, there's always a chance of residual pain or stiffness after surgery. Now, we are correcting a bony deformity, but you do still have all your soft tissue around your hip. And so sometimes, especially as scar tissue forms, that can cause some residual stiffness or pain. Again, rare that would happen. There's always a small risk of fracture, which we would address during surgery. And then these last two are a little bit more common. Sometimes you'll experience some clicking because you now have mechanical components in that hip. As long as it is not accompanied by pain, it is not something that we worry about. And then insomnia can sometimes be fairly common, especially in the early stages after surgery, because anesthesia can sometimes mess with your sleep-wake cycle a little bit, and especially pain overnight can keep you from getting a good night of sleep. But that should go away with time. So you've been scheduled for a hip replacement. Now what do? The most important thing to start with is calling your primary care provider. You will need medical clearance for surgery. And if you have a cardiologist, you will also need cardiac clearance as well. This is required by anesthesia to put you to sleep. So if you do not have this, then they will not put you to sleep and we will not be able to perform the surgery. What's important to remember is that this needs to be done within 30 days prior to surgery. So if you're not scheduled for another 3 months, don't rush right out and make all these appointments because if they're not within 30 days prior to surgery, you may have to repeat these appointments before surgery. Now, if you've recently seen either of these doctors, there's a chance they may be willing to sign off on your clearance without actually seeing you for an appointment. It's just really important that you let them know, hey, I'm having surgery, and see how they want to proceed. Now, you will need some medical equipment after surgery. What's super important, the most important thing that you get is a walker. We do ask that you get a walker with 2 wheels on the front and no wheels on the back. And because that is going to be the most stable type of walker. If you get a walker with wheels on all 4 sides, then that is liable to just slip right out from under you, especially if you're not used to using one like that. Now, for a lot of people, they do transition from a walker to a cane. And so a lot of people like to have a cane on hand. And especially for a hip replacement, a toilet lift can be very helpful, especially if your toilet is very low to the ground. A shower chair can also be nice, so you don't have to stand up in the shower the whole time when you're still feeling a little unsteady. And then for some people, they like to get an ice machine, but others just enjoy using regular ice. And then if your surgery is scheduled at the outpatient surgery center here at Coastal Orthopedics, you will need to make sure that you've had lab work and an EKG done. Now, most often, your primary care provider will do this for you, but if they do not end up doing this, you need to just let us know, and we're happy to order those for you. If your surgery is done at the hospital, then the hospital is in charge of doing your preoperative testing. They should be reaching out to you to give you that appointment, but if they don't, you let our team know and we'll be happy to figure out exactly when you're supposed to go in for that. After surgery, it is very important that you ice the surgical area. Ice helps reduce swelling and it helps with pain. And there are a couple different ways that you can do this. One, which is the cheapest and easiest way, is to just get some good old-fashioned ice packs. Now, I do recommend the blue jelly kind that can kind of morph around your hip. There's also the option to get an ice machine. Now, you've probably heard from people in your community about ice machines. I will say ice machines do tend to be more important for a knee replacement than a hip replacement, but some people find that the ice machine is really helpful with a hip replacement. So we have an ice machine here that you can buy. It is not covered by insurance, unfortunately, but if it's something that you're interested, you should go ahead and call our assistant, Sean, to get that scheduled. There's also a company that does a rental ice machine. It's a very fancy ice machine that also combines some compression. Again, this does tend to be a little more important for a knee replacement than a hip replacement, but you may find that this could be helpful for you. So what else do you need to do to prepare for your surgery? The biggest thing is that you're going to want to plan for your recovery at home. Make sure you're taking adequate time off of work. For most people, that's going to be at least 4 to 6 weeks. Obviously, it's going to depend on your level of activity at work, but definitely at least 4 to 6 weeks. You're definitely going to need somebody at home with you for at least the first couple of days after surgery to do things like help you in and out of bed, get to the bathroom and back, getting dressed, preparing food, all that kind of stuff. You are going to be unable to drive for a couple of weeks. Now, if you are having surgery on your right side, this is going to be a strict 4 weeks at least, because that is your pedal foot, but you're definitely going to want to have someone set up to drive you to your appointments, at least in that early stage. If your surgery is being done at our outpatient surgery center here at Coastal Orthopedics, we do have a phone number here, and this should also be included in the packet that you received, that you are going to call the day before surgery between 2 and 4 p.m. They're going to tell you exactly what time your surgery is going to be. If your surgery is being done at the hospital, then the hospital should be calling you the day before to give you your exact arrival time. Now, if your surgery is on a Monday, they will be calling you on Friday, and usually after about 5 p.m. to give you that information. So make sure you answer any weird phone calls on that day. Definitely do not eat or drink anything after midnight, the night before your surgery. And now we have a list of medications to stop prior to your surgery. So as far as over-the-counter medications, that's going to be anything in the NSAID family. We're talking ibuprofen, Aleve, Motrin, naproxen, any multivitamins or supplements, aspirin, and then fish oil. If you're taking a blood thinner, it's going to be very important to talk to your primary care or your cardiologist, basically whoever prescribes that blood thinner, as to exactly when it is safe for you to come off of that blood thinner, because it's going to be different for every single one of these. Examples of these are Plavix, Coumadin, warfarin, Eliquis, Xarelto, and definitely speak to them about that. You are still allowed to take Tylenol, Celebrex, or meloxicam for pain prior to surgery, but that you're going to be pretty limited to just those. Now, what is going to happen the day of surgery? So you will show up to either our surgery center or to the hospital. They're going to take you to the preoperative area. That's where Dr. Harkess is going to come by and put a signature on the correct side. And then anesthesia will come in and meet you. If you have any anesthesia-related questions, now is the time to ask. This is also the time to tell them if you've ever had any issues with anesthesia in the past, especially if that's something like nausea or vomiting. That way they can pre-treat you prior to surgery. Now, with a hip replacement, they will either give you general anesthesia or spinal anesthesia. Again, that will be the decision of the anesthesiologist, and they will talk to you about that morning of. Once you are awake, you will be in the recovery unit, and there you will be monitored until you are either ready to go home or up to the floor if you're at the hospital. Your family members should be able to visit you once you are awake enough to interact with them. And if your surgery is at the outpatient surgery center, you will be able to be discharged home the same day. If your surgery is at the hospital, you sometimes will qualify to go home the same day as long as you're meeting all discharge criteria, meaning that you're fully awake, you've been able to walk with your walker, you're tolerating food, and you've peed. Then you should be good to go. If the plan was already for you to stay the night, or if you don't meet any of these criteria, we can absolutely keep you at least a night in the hospital. As far as your incision goes, we do a posterior approach hip. Now, posterior doesn't mean your incision is all the way in the back. It's usually more on the side, and your incision is usually about this long, easier to see on this diagram down here. So we will be closing you up with sutures underneath your skin that will dissolve on their own, so no stitches or staples to get taken out. We use skin glue over top of that as an added layer of protection, and then a really nifty dressing called an Aquacel dressing. That dressing is waterproof, so you can shower with it on. It's super flexible, so it should move with your hip, and it stays on for 7 to 10 days, so it's really easy to take care of. It will not fall off on its own, though. It is very adhesive, so either you can take that off at that 7 to 10 day mark, your physical therapist can take it off, or if you feel nervous about either of those options, I am happy to take it off at your first 2-week post-op appointment. Once it does come off, you're still allowed to shower. So you have no precautions on showering whatsoever throughout this process. But I do ask that you do not pick at your skin glue. Don't scrub it hard in the shower. Just let the water gently flow over top of it and pat dry with a towel. And as I mentioned, showering is fine, but what we don't want you doing is soaking activities. So we're talking bathtub, pool, hot tub, ocean, and that is for 6 weeks after surgery. We also ask that you do not put any lotions, creams, or ointments within 2 inches of your incision for 6 weeks after surgery as well. So this includes scar creams. We also recommend that you protect your incision from direct sun exposure while it is healing, because otherwise that direct sun exposure, especially if you get a sunburn, can really make that scar more visible in the future. Now, as far as pain control after surgery, my goal is to hit your pain from as many angles as I can to limit the amount of narcotics that you end up needing to take. So the top 2 medications on this list are your non-narcotic pain medications that I actually am going to want you to take on a scheduled basis after surgery. So we're talking Tylenol, 2 500 milligram tablets 3 times a day for at least 2 to 4 weeks after surgery. And then we're also going to give you, as long as you don't have any contraindications, meaning you don't have any kidney disease or you're not on any blood thinners, we will be giving you an anti-inflammatory. So that will either be Celebrex or Meloxicam. And this will be dosed once a day for 30 days. So Tylenol and Celebrex you'll take no matter what. Now, the goal with these is not necessarily to bring your pain down to a 0 because you just had major surgery, but what they can do is lower your pain level down just enough so that hopefully you won't need the narcotics as often. And that way, as you're weaning off your narcotic pain medication, you still have something baseline in your system treating your pain. So the last 2 medications on this list are tramadol and oxycodone. These are both technically narcotic pain medications, but they are different strengths. They are never meant to be taken at the same time. It's meant to be an either or based on the kind of pain that you're having. So oxycodone is much stronger. That's for severe breakthrough pain. Tramadol is much weaker for more mild to moderate pain. So again, it's going to be an either or based on the kind of pain that you're having, and those can be taken on top of the Tylenol and whichever anti-inflammatory you've been prescribed. Now, in addition to the pain regimen that we just talked about, we are also going to need to give you a medication for blood clot prevention. Now, we talked about this way back when we talked about risks, but for most people, to prevent blood clots, we are going to have you taking a low-dose 81 milligram aspirin twice a day for 4 weeks after surgery. This is an over-the-counter medication. You can just pick it up right from the pharmacy. Now, if you have any allergies to aspirin or cannot take aspirin for any reason, or you have a history of blood clots, especially after surgical procedures, we are going to give you something stronger. Likely that will be a medication called Xarelto, also for 4 weeks, so the length of time is not going to change. If you are already on a blood thinner, then we will simply just restart your blood thinner the very next day after surgery. Now, those narcotics that we just talked about, the oxycodone and the tramadol, can both make you very nauseated and very constipated. I do recommend you always take them with food on your stomach because that'll help with that nausea. And as far as constipation goes, we do ask that you take a stool softener. Now, this is meant to be a preventative medication. This is not meant to treat constipation after it's already started. It's meant to prevent it in the first place. So as long as you are still taking those narcotic pain medications, I do ask that you take a regular stool softener. It's not a bad idea to have something stronger on hand that is more in the laxative family, just in case. And if you already know that you're prone to constipation with narcotics, definitely want to have something stronger on hand. The other things you can really do for constipation are making sure you're staying nice and hydrated and that you're moving all around. So some of the biggest questions we get asked are, what symptoms should I be worried about after surgery? So after a knee replacement, it's very common to get swelling in your leg, to get bruising. Like I said, that goes all the way down to your ankle. Same with that swelling. It's normal for your knee to be warm because there's all kinds of extra activity going on in there to heal everything. Sometimes it's normal to have a little tiny bit of redness around that incision, or if you get a little irritated, if that redness is just in the footprint of your dressing, then likely you just had a slight reaction to the dressing itself. As well as a low-grade temperature. We're talking anything below 101 degrees. So that is often caused by people being in pain and not taking big, deep breaths after surgery. So if you notice you have a really low grade temperature, any 99, 100, the thing that we would ask you to do first is sit and take some very deep breaths. Take at least 10 big, deep breaths an hour. Try doing that for a couple hours and take a Tylenol. But if you have any of these symptoms and you are concerned in any way, shape, or form, definitely give us a call. We're always happy to discuss, and we're always happy to see you back if you feel like you just need us to take a look. The big things that we do want you to call us back on is if that swelling in your leg turns into major redness and you have a lot of pain in your calf. Any fever is greater than 101.5, definitely let us know. Any significant drainage from your incision, pain that is uncontrolled with your pain regimen, and redness that seems to be getting worse. Give us a call. So what can you expect after surgery? Most patients are using a walker for about 1 to 2 weeks after surgery, after which they progress to a cane or nothing at all. Usually starting to run around town, maybe run a few errands, about 2 to 4 weeks after surgery. Usually plan on shorter trips at the beginning. Bring your walker and cane with you in case you need it, especially if it's on uneven ground. Most people are returning to things like a desk job or the equivalent activity in about 4 to 6 weeks. And it won't be until 6 weeks that we take you off of your posterior hip precautions. So that means no bending past 90 degrees at your hip, no picking things up off the ground, and no crossing your legs. Again, that's not for forever, just for the first 6 weeks after surgery. After about 3 months, we usually like you to consider this a full-time job for 3 months. Not because you're going to be debilitated for a full 3 months, but because it is super, super important that you do your exercises every single day for at least that first 3 months. And physical therapy is going to be very important to all of this. Most people get it 3 times a week for at least 6 weeks after surgery. But what's happening in that first 3 months is that scar tissue is starting to form. And if you don't get this thing moving, then sometimes that scar tissue can kind of sock everything down and make it really stiff. So definitely keep moving after surgery. And then when it comes to driving, if your surgery was on the right hip, then we ask that you do not drive for 4 weeks because that is your pedal foot. And studies have shown that your reaction times are just not where they need to be for the first 4 weeks. If we do your surgery on the left and you drive an automatic car, the only rule as far as driving is concerned is that you just have to be off of all narcotic pain medication. After surgery, as long as you have had no complications, we have a pretty standard schedule as to when we see you back. Usually, that's going to be 2 weeks after surgery, 6 weeks, 3 months. So that's all in the early stage. We do always bring you back for the 1-year anniversary of your surgery, and then every 3 to 5 years after that, or obviously as needed. If you have any issues whatsoever, we're always happy to see you in between these appointments. Now at 2 weeks, we will do a wound check. Your dressing will be removed if it's still in place. We do always take x-rays at this visit. At 6 weeks, we will clear you for swimming and lotions, and this is also when you can stop following those hip precautions. Again, that's bending forward, crossing your legs, things like that. At 3 months, most people are doing awesome by 3 months, and this visit is pretty short and sweet, but we will just quickly take a look at your incision, make sure everything's still going well for you, and we'll clear you to go back to see the dentist. Now, at your 1-year post-op visit, we do take repeat x-rays to make sure everything still looks good. Now, as I just mentioned about the dentist, it is going to be very, very important that you do not see the dentist, even for a cleaning, for 2 weeks prior to surgery and 3 months after surgery. Then, for the next 2 years after surgery, you will need a 1-time dose of antibiotics every time you see the dentist. For most people without any allergies, that's going to be 4 pills that you take 1 hour prior to your appointment. Usually, your dentist will prescribe those for you, but there are some dentists that would prefer us to do that, and we're happy to send those in for you. You just got to let us know when your appointments are coming up. Now, that is the end of our presentation here. Again, if you have any questions whatsoever, I hope you wrote them down, and we will be giving you a call prior to your surgery just to address those. But also feel free to give us a call at any point, especially after surgery, if you have any concerns, and we'll be happy to address those. We are very excited to undergo this joint replacement journey with you, and we are very hopeful that we are going to get you to a pain-free, more functional place after surgery. So we look forward to seeing you again soon, and I hope you have a lovely rest of your day.